Yes, I'd like to ask a question about the progress of these clinical trials. Is there any feedback on them as yet?
Not at the moment. So, but I mean, I think motor neurone disease is lucky in a sense that there's a lot of money going into clinical trials, and I think an answer will come soon. And I mean, I also treat patients with kind of Alzheimer's disease and frontotemporal dementia, and there are no trials. And so I think there will be an answer. It's just kind of, and I think it will come by serendipity. One day one trial will work, and that will be other.
You mentioned that early detection and treatment is more effective. Does it then follow that if you have had
Attention
MND
staff,
in your
marshalling
family,
required at reception.
if you have had MND in your family, then the prudent course would be to be genetically tested and ascertain whether or not you do have one of those 25 genes?
Yeah, I mean, usually we only test people where there's a strong family history. So that's people where multiple generations have had either FTD, motor neurone disease, or something that sounded. So sometimes we get people who come and say, oh, my grandmother was diagnosed with MS, but it wasn't really, it was kind of that diagnosis that nobody talked about. And then the mother had MND, and now I've got MND. Usually we test patients where there's a strong family history, because, I mean, I wouldn't advise if just one person had developed motor neurone disease being tested.
The question from the audience is regarding whether or not Parkinson's also has some variant.
So this is a bit like, so Parkinson's disease is separate from motor neurone disease, but sometimes people with Parkinson's disease, before we had, imaging techniques and diagnostic criteria, may have had motor neurone disease. So this is kind of 50, 100 years ago. And so if someone at the moment's got Parkinson's disease and a patient's got motor neurone disease, then I'd say they're probably separate. But it's more if, say, you've had multiple generations in your family diagnosed with Parkinson's disease, then you start to think, oh, maybe it wasn't Parkinson's disease.
With regards to alternative to Relazole, I believe the Rebekah or the Edra has been now listed in the US and in Canada as a BBS. Are there any trials being done in Australia?
Not that I'm aware of, but I mean, there are some, we do have patients who pay for it and get it from overseas, but it's not listed on the PBS here. Any other questions?
Is it best to get off of cholesterol-reducing medication if you've got motor neurone disease?
Yeah, so what I would say is go and talk to your doctor and obviously your cardiologist and do it together. I wouldn't advise anyone just to stop a medication without talking to their treating doctor. But if there is no if it's just that you're on the cholesterol medication to reduce your risk of having a heart attack, over a 20-year period, we would stop the anti-cholesterol drugs.
Yes, I've been on those drugs for 30 years. They've worked.
Yeah.
Reduce my cholesterol level, but if they're very bad for motor neurone disease, then I'd rather give them up.
Yeah, what I would say is go and talk to your doctor because they would know.
Eat more ice cream, chocolate.
Yeah. I think the most important thing is and there are clinical trials looking at how a high-fat diet will affect your survival. The results aren't known yet. But we know that having a higher cholesterol, having a higher body mass index does people better.
Volunteer for those tests and
yeah. I think there's another question.
I've got a question from the audience here. Is there any connection between trauma or having a blood transfusion and MND?
No.
I'm sorry, I have a question. Some of the information that you disclosed in the PowerPoint was in relevance to how sugar is so needed because of the increased energy expenditure. Are there any trials or any sort of better understanding or drugs that can be taken to support either the electron transport chain or support around the glutamate pathway?
You mean in regards to the sugar? Yeah, I mean, so we're doing studies at the moment looking about how modifying your diet can affect your survival.
I was looking at more of the nutraceutical type of components that can support the energy.
Yeah, at the moment, I'm not aware of any studies there. I mean, in patients with, for example, Alzheimer's disease, you can buy those from the chemists, kind of those protein, and I think they're kind of nutrient drinks. I mean, if people wanted to, I'm not aware of any studies looking at that in motor neurone disease, but I mean, if a patient came to us and said they wanted to trial that, I don't think there's any reason why it would do any harm. But I don't think there are any direct studies, because at the moment the things around kind of metabolism is a new area of research, so it's kind of going first. Usually how they start is looking clinically, defining the pattern clinically, and then you start to look more at how those changes affect the underlying cell metabolism in animal models. So we're kind of only just starting to do that. Yeah.
I just wanted to, as you talked about the trials, so is there any evidence that says that transcranial magnetic stimulation is good for MND?
There's no evidence that it's good for MND. We use it as a diagnostic tool. So we use it to help diagnose patients and help differentiate different diagnoses that have weakness. But I'm not aware of any clinical trials that show that it actually improves patients. And I think there are studies in Alzheimer's disease. I'm not sure that the kind of results for that are valid at the moment. I think we need bigger studies.
Is there any evidence that iron levels do drop through MND?
Decreased through M.
The iron levels.
Yeah, I mean, there's no kind of solid evidence that iron is associated with MND. I mean, we do have patients, for example, that come with really high iron levels and go through multiple blood transfusions to try and lower their iron levels. But I don't think that's I wouldn't advise that.
But what if you have low levels?
Low levels, I mean, I think low levels, I would replace your iron levels more for fatigue and energy.
What about the CPK levels or CK levels? I know they are high in myopathy or inflammatory myopathy, but are they necessarily high in MND?
No, so we wouldn't expect patients with MND to have a high CK level. So patients with MND might have a CK level of around 300 just because there is some muscle breakdown, and usually we test their CK levels after we've stuck a needle in them to do the neurophysiology, and that will raise your CK level. If someone's got a CK level kind of 20, 30,000, that would suggest there may be something inflammatory.
And what about the biopsy? Is it a kind of like you can detect whether it's MND or no, that doesn't help?
Yeah, so a biopsy would help. Usually we don't need to send patients for biopsy because we, usually the diagnosis is readily available clinically. So there are studies looking at when a neurologist suspects MND, how accurate are they? And the results are about 90 to 95%. That if you suspect an MND, that's probably the diagnosis. Then we use the neurophysiology. We may do brain imaging or a PET scan, which looks at the functional activity of the brain, just to confirm the diagnosis. We wouldn't go to do a muscle biopsy unless we were unsure about the diagnosis or we thought something else was going on. Any other questions?
Rebekah, could you just explain what a CK?
Oh yeah, sorry. So CK, it stands for creatine kinase, and essentially it's a protein that's released into the blood when there's muscle breakdown. So we use it most clinically. We used to use it when people had heart attacks, for example, and the heart muscle was damaged. Then CK levels tend to rise because it's released into the blood. We use it in neurology when patients have what we call inflammatory muscle conditions. So those patients would tend to present with a lot of pain, and they get usually muscle weakness proximally, so shoulders or hip muscles, and they have a lot of pain, and then we check the CK level and it's usually in the thousands. Oh, there's...
From what you've said today, and what I've been reading on some of the sheets that I've been given, they're saying that inflammation is affecting the proteins in the, I think it's the nervous system. Is there anything being done about trying to treat the inflammation at all?
Yeah, so that's one of the trials that's now running on Tecfidera. So Tecfidera is an agent that we've used for a number of years in multiple sclerosis. So multiple sclerosis is a neurological condition where you get inflammation in the brain, and so they're trialling to see if that might have some effect in motor neuron disease. And there are studies around the world looking at the inflammatory basis of motor neuron disease. So if there are blood markers of inflammation, and trialling at an animal level and also a cell level, how targeting those, they're called cytokines, might affect the progression of the disease.
So it's not controlling humans?
No, there's a Tecfidera study.
How often is poor appetite characteristic?
Yeah, so that is, so we see a group of patients, so there's a group of patients that tend to have more cognitive change, that have the overeating behaviours, and then there is a group of patients that have poor appetite. And I think Shu might talk about that this afternoon. The cause of the poor appetite isn't known. There is some evidence that patients describe a metallic taste in their mouth, and that might be somehow responsible.
Another question is digestion affected? I find I have to go for a 5-kilometre walk after each meal.
Yeah, and I think that's very much related to autonomic function. So we know the autonomic nervous system has nerves that go to the bowel, and that controls your digestion of food. And so a lot of patients describe changes to the autonomic system, so that's constipation, the changes in temperature regulation, changes in blood pressure control, things like that.
You described loss of sympathy as one of the other aspects. Is it possible to have a perfectly acute memory, so show no signs of diminution of memory capacity, but have some of the other functions such as loss of sympathy or...
Yeah, absolutely. So memory function is a bit further back. So the temporal part of the brain controls memory, where the frontal lobes control behaviour and personality. So that's your ability to reason with people, also to see their point of perspective, and to empathise with them. So a lot of patients, and it's difficult because how do you tease apart that this terrible thing has happened to this person and versus what's part of the disease and their reaction to it, and then what's changes in empathy that's actually part of the disease. But there are definite changes in empathy and ability to see other people's perspective, and sometimes there are more frank changes in personality. So I've had patients who start, for example, shoplifting, kind of doing inappropriate things like that. So it can be kind of right from just subtle changes to quite prominent changes.
Does low level of cortical excitement have anything to do with ALS?
Yeah, so that's, we detect cortical excitability by doing transmagnetic stimulation. And so that's a test essentially where they put a magnet on your head and pass currents through the magnet and look at how your brain conducts that magnetic radiation. And essentially, patients with MND can start off with changes in their excitability. So it can be inexcitable, so we can't excite the cortex with the magnetic stimulation, and then they can develop what we call hyperexcitability as the disease progresses. So there are treatment looking at targeting the levels of excitability, but they're not available. They're much more still kind of in cell and animal models.
Oh, there's one.
Doctor, as you mentioned, it's important to take riluzole as early as you are diagnosed with MND. So just in my case, like I was treated for polymyositis for a year and a half, and after that it was decided that it's MND. So that's when I started taking the riluzole. So just asking, how would it affect, like a year and a half, I was on heavy dosage of, what you call prednisolone and azathioprine, and taking IVIG treatment. And then it stopped and suddenly, and then I had to be on riluzole. So would that have some effect on the kind of benefits that I would know?
No, and I mean, I don't think it would affect your kind of outcome. And I think one kind of positive way to look at it, if the hypothesis is right that maybe inflammatory, there is an inflammatory basis to motor neurone disease, then you've had IVIG and you've had some immune modulating drugs as well. So, but I'm not advocating that everyone goes and has that. But just in your case, that I wouldn't feel bad that you hadn't had the riluzole at the very beginning. I think often it is hard to diagnose patients and it does take time. And so I don't want you to feel like, oh, I haven't had the riluzole, therefore I've missed out. I don't think we can say that at all. And I think kind of a silver lining is you've had a lot of immune modulating treatment, so maybe that did have some benefit that we don't know about.